So we started thinking about this probably a couple months ago about how we could increase or different models of interacting between people in the field who may be living with mental illness or substance misuse, and how is it that they come into contact first, usually with by first responders. One of the things that's remarkable about Colorado is an extremely robust both emergency medical services system, but also very progressive kinds of law enforcement and policing. And so as somebody who lectures and talks and writes about these sort of things, I can say with some confidence that the people of Colorado are well served, largely because of the creativity and the energy of particularly people who are involved in our program today. And so when we were thinking about the program, one of the things we wanted to address was both issues that affect urban Coloradoans, but also those in sort of suburban and particularly fairly rural. We're going to pick on Sheriff FitzSimons a little bit because he is by no means in an urban area, certainly has a rural response, but also has sort of a suburban. There are a lot of folks in Summit County that come down to Denver for work. So we're going to start with James McLaughlin today. James is the PACT program manager for the Ute Pass Regional Ambulance District. He looks after this, he's going to tell us about this PACT program, but it was put in place and designed to meet the needs of individual populations that historically have been neglected by different models of healthcare. And so please welcome James.
Thank you, Tom, for that kind introduction, and thank you all for being here today. I'm really excited to talk about our program and what we're doing for the citizens up here in Teller, Park, Douglas, and El Paso counties. I'm with Ute Pass Regional Health Service District. We serve 539 square miles of mostly rural environment. We have 16 providers and respond to about 3,000 calls a year. Of those calls, about 20% of them have a behavioral crisis or substance use disorder crisis component associated with them. So, and in 2014, we started looking at different ways that we could serve our populations, and we did a community needs assessment. What we identified was there was a real underserved population in our community. There was folks that were fairly marginalized and not receiving the services as effectively and as efficiently as they deserve. And that was hard for us. We also identified the fact that we have, just by the nature of EMS, we have some reserve capacity built into our system. We have to have providers ready to respond to calls. And so we wondered if we could marry these two together. And so what we did is we put all of our providers through a 520-hour didactic training, all of our paramedics. So they've already gone through, most of them have an associate's degree in paramedicine. Over half of our providers have bachelor's degrees as well. And we went ahead and put them through an additional 520 hours of didactic training around community-based paramedicine. And that was, we took a biopsychosocial approach and looked at how you can treat the whole patient, not just the physical needs of the patient. So that was taught by Pikes Peak Community College, an accredited community college in our region, and utilized the National Community Paramedic Curriculum. In addition to that training, we put all of our providers, all of our paramedic providers through motivational interviewing, through a 5-day motivational interviewing course. We put them through screening, brief intervention, and referral to treatment, and the EMS provider resiliency program, because we thought if they were going to be out there treating other folks, we wanted to provide them with the tools that they could themselves make sure they're taking good care of themselves and their fellow providers. So at the end of that program, they also did an additional 520 hours of didactic or of practical training, where they sat in with community health workers, with psychiatrists. They also spent time at the behavioral health facilities doing intake work. And then from there, we created a program called the Mental Health Assessment Program, or MAP. And that's really what it is. It's a map to alternative destination and alternative services. Historically, the way ambulance services worked is when somebody's in crisis, they call 911, a big, bright, shiny red fire engine shows up, and a very expensive ambulance shows up, and the engine has 4 or 5 people on it, and the ambulance has 2 or 3 people on it, and then 2 or 3 police officers show up. We have 10, or more people crowded in this room around this person in crisis. We then drag them out of their house, none of us with the training or skills or ability to do that, and then take them to an inherently unstable environment, an emergency room, where they sit for 12, 24, 72 hours or more. And then we wonder why, A, our healthcare system is so expensive, and then B, why these patients aren't getting better. We're re-traumatizing folks through that process. And so our approach is we take these well-trained community paramedics that have a lot of community resources, and that's the most important piece, is we don't do this alone. We're not the content experts. We have just enough training to be dangerous on our own. Really what we count on is our community partners. We work collaboratively with our community partners. The first thing we do is we come in, we utilize motivational interviewing, and we try to de-escalate the immediate crisis. So we come alongside the patient. We try and understand what motivates them, what's driving the current crisis, and we actively listen to them so we can hear them mention change behavior. And as soon as they identify what it is that motivates them, then we work with that to help them gain the tools to evade the immediate crisis. Once we've got them de-escalated, and this could take anywhere from 10 minutes to 2 hours, and our providers are empowered to spend as much time on scene as they need to help that person, to do it in their timeline. So once the crisis is de-escalated, then we medically clear them utilizing a 28-point peer-reviewed criteria that says, yes, this patient is medically stable and medically appropriate to proceed to the next step. So we do things like blood pressure, physical assessment, alcohol screening, drug screening. We do lab work, things of that nature. Once it's clear that the patient is medically stable and medically appropriate, then we do SBIRT, which is screening, brief intervention, and referral to treatment, to identify any substance use disorder, co-diagnosis type issues. And then from there, we do a Columbia suicide severity screening and an internal lethality assessment screening to identify the potential for suicidality, homicidality, whether or not they're gravely disabled, and then to what degree they might their homicidality or suicidality might be lethal. So they're then stratified into a green light, yellow light, red light approach. And once that's determined, if they're in the red light category, that means that they're either suicidal or homicidal, have an active plan and intent. With those patients, we attempt to reach out to our partner, used to be Aspen Point, now it's Diversis, and we do a telebehavioral health assessment with a licensed clinician. And then that clinician determines whether or not that client meets the criteria for an M1 hold. If they do meet the criteria for an M1 hold, then they place them on an M1 hold and send us an electronic copy of that M1 hold. And then we work to get the patient placed at one of our behavioral health facilities, and then work it from there. And then we actually we do the nurse to nurse, we get them accepted by the receiving provider. We provide them with all the information, and then we directly transport the client to that destination, not utilizing an ambulance, utilizing a secured SUV that does not look like a police car. We really wanted to get away from that institutional, I'm going to jail kind of feeling. So for us, that's worked really well. And then if they're not on an M1 hold, they don't need immediate placement, then we work with the licensed clinician to get them placed on a safety plan. So that would be our yellow light category. and then get them set up with counseling. So we don't just say, hey, here's the number, call a counselor. We actually work to do a hard handoff or a hard referral where we have a date and time that they're going to be meeting with that provider. And then we model what it looks like for that client to actually go to that facility. So what, how are you going to get there? Do you have transportation issues? Can we address those for you? And then we work with our transportation partners, either the Senior Coalition or Ready Cab or one of those services to get them a ride if they need that. And then from there, if they're not in that red light or that yellow light category, and they're in the green light category, mild depression, just struggling with the stresses of life, but they're not suicidal, they're not homicidal, they're not in immediate crisis. Then what we can do is we can do soft referral handoffs where we give them a list of providers and suggestions and get them tied in with local services. So we also, identify barriers to accessing care, such as if they don't have insurance or things of that nature, then we try and address those issues as well. And then for the substance use disorder population, especially if they have a behavioral health component to it, that group is those folks, we really historically struggled with managing them and getting them to the right services that they needed. Now we've teamed up with Crossroads, which operates 2 detoxification centers in our community. So we get those patients, if they're actively under the influence or in withdrawal, then we get those folks set up with that detox facility. We medically clear them again, do telehealth visit with a ED certified physician, and get them any medications they might need to be successful through their detox process. We actually go and pick those medications up for them on the way to the detoxification center, and we take them there directly. So from there, we also work with several private detox facilities. So if a client would rather go to a private detox facility, then we work with them to get them there, kind of in the same process. And then if somebody needs to be on an EC hold, all of our providers have been trained on how to write EC holds and how to proceed with that application for emergency commitment. So we've been doing this since December of 2014. We've calculated about $3 million in downstream cost savings directly from diverting patients away from the emergency room unnecessarily. And we have about another 250 to 500,000 in associated or wake cost savings from not having to send an ambulance and a fire engine to every single call, not having to send 3 or 4 police officers, freeing up the police to leave fairly early so the law enforcement officers can get back into service, and keeping those resources available for other calls. So on top of everything else, for us, it's a force multiplier, because instead of taking 2 people in an ambulance out of service to bring somebody down to Colorado Springs, which is a 2.5 to 3 hour round trip, we have one provider that's dedicated to that person throughout the time it takes them to get them appropriately alternatively destinated to the best facility for them.
James, this is remarkable. If I could interrupt you for a second.
Yeah, absolutely.
We just want to make sure that everybody knows that this is being recorded, and we're going to post it on the CHEF website later. And so we appreciate people letting us do that. The other thing I wanted to ask you, and this is a remarkable program, the community paramedic is far different than the typical paramedic who's showing up off of a fire truck. It's a lot more training. But I'm just sort of curious, how is it that these individuals access you? And so if I'm in your community and I'm having a tough time, do I have to call a special number? Tell us a little bit about that. And then tell us a little bit about your role with the Colorado Crisis System, which allows people to call one number and have an assessment if need be within 2 hours, if you wouldn't mind.
Absolutely. That's a fantastic point. So we believe in all points of access. There's no wrong entry point into our services. So as Tom hinted at, you can access us through accessing the Colorado Crisis Services. So you can go to the Colorado Crisis Services website. You can text them using the Colorado Crisis text number, or you can call the 1-800 number to access Colorado Crisis Services. I have to apologize. I don't have that number for you right this second. I'll have it for you here in a minute. But you can access the Colorado Crisis Services directly through any of those resources. and the rule is that within 2 hours of the request, and actually within 1 hour for certain areas, we will be on scene. We've never had a problem, knock on wood, meeting that response time. Generally, we're on scene within 15 to 20 minutes of the request. But we also take requests from any law enforcement officer in our community that we work with. We also take requests from private physicians' offices. We take requests from, we actually work with our local critical access hospital because they don't have a behavioral health person on staff full time. So they can actually access us anytime, day or night, 24 hours a day. We'll send a MAP medic over, or a community paramedic with MAP services over to do an assessment of a patient that's in the emergency room, either with substance use disorder or behavioral crisis. Also, if one of our providers on the ambulance or one of our local fire agencies arrive on scene and they identify a client who's in behavioral crisis or in substance use disorder crisis, they know that they can refer to us and make a request. That not only includes folks within our district, but if the ambulance, EMS services, and law enforcement agencies outside the area are willing to drive within our district, we will actually rendezvous with them at set safe locations and do the assessments there. The thing I'm most proud about and what I'd like to end with my presentation today is these are hard clients that we're working with. They're in their darkest hours and they're really struggling to find the services that they need. But what we've been remarkably surprised with is on a scale of 1 to 5, where 5 indicates absolutely excellent service, the score that our average score for satisfaction from our clients is 4.6 out of 5. So not only are we reducing the cost of care and improving access to care and making sure that clients get where they need to, when they need to, we're also doing it in a way that makes them feel and empowers them to be part of the process and have some say in what happens. And I think that's so important for them. So with that, I thank you guys for your time, and I look forward to hearing the rest of the presentations.
James, it's a remarkable program that you have. And for people who are not familiar with first responders and how the EMS system typically works, it is a remarkable program that my only fear is how difficult it may be to duplicate. Where is it that you've gotten your funding, and how is it that you partner with your 911 center? Maybe you could tell us a little bit about that. And then if anybody else has questions, if you put them in the chat for us.
Absolutely. So in building the program, the first thing was collaboration and working with partners. So one of the things we did early on is we adopted an already peer-reviewed, evidence-based assessment tool. And then we went around to all of the physician advisors for all the behavioral health facilities. And we said, hey, here's an evidence-based tool. You can add anything you want to this tool, and you can take anything away from this tool that you want. All you have to do is bring the evidence to support it. So we settled on the 28 criteria, and we haven't had, knock on wood, we haven't had a single sentinel event since we started the program in December 2014. We've been able to safely transition each and every one of these patients to alternative destinations. So we reached out to all of our law enforcement partners. They run the dispatch centers in our community, and we shared our vision with them, and they were like, yeah, no, this is amazing. This is exactly what we need. And every single one of our law enforcement partners has embraced the program since day one. So that was really how we got dispatch involved. And then our funding is multifaceted. First of all, in a rural environment, ambulances don't make money at all. I mean, you bill for services, but the reality is you collect about 20% of what you bill. And so you're losing money. So we are a tax-based entity. We receive a small mill levy and a 0.5-cent sales tax because we're a health service district and not an ambulance district. And that offsets about 60% of the cost of the program. And then the rest of the program costs come from the Colorado Crisis Services contract. So we are a subcontractor through Beacon Health Options, and they are the Southern State contractor for the Colorado Crisis contract through Office of Behavioral Health. And then we receive funding from them to provide the services that we provide. And the cool part about that is there's never a charge to the client for the services that we provide. So if they're transported to an alternative destination, they never receive a bill from us. If we assess them on scene, they never receive a bill from us. They can reach out to us as many times as they need to and get the services that they need. And then we've teamed up with a couple of partners that really add some back-end power to this program, and that is Front Range Clinic. They offer mobile medication-assisted treatment in our community. That's the first time that's ever been offered. So if you have someone with opioid addiction or other substance use disorder crisis, we can actually get them in, get them set up. Those folks come in once a week to our office and provide the services in our parking lot literally from a Winnebago. It's not a flying Winnebago, but a Winnebago. And then we've teamed up with Viewpoint Psychotherapy, and once a week, that's actually why I'm kicked out of my office today and I'm working out of the classroom, is once a week they take over my office and they see patients who need medication assistance. So we all know that with behavioral crisis clients, one of the things they suffer with is maintaining medications. And so we brought this nurse practitioner in. Before she got here, the average wait time for one of our clients to get into medication treatment for their behavioral crisis, to get with a prescriber, was 30 to 90 days based on their payer. Now we can have them with that nurse practitioner within 7 days.
It's remarkable, James. It's just remarkable.
It's such an awesome component. We also have formed the Teller County Mental Health Alliance, which is a bunch of behavioral partners in the community that have come together. And once a month we meet and we set goals and objectives, and we have core measures that we measure. And we've got a governance, and right now what we're building is actually an internal referral service. So, when you make the referral, when the referral is received, and when it's been acted on, and what the outcome of that referral was. So we're real excited about that piece. We're hoping to have that online within the next year. And then finally, our last partnership is also with Viewpoint Psychotherapy, where they do follow-ups on any patient that's seen in an emergency room in Teller, that lives in Teller or Park County. So if they're seen in any emergency room in the state and they live in Teller or Park County, then they get for behavioral or substance use disorder crisis, they get a follow-up within 5 days to make sure that they understood their discharge instructions and that they were able to get set up with the services that they need. So
it's just something remarkable. You all are absolutely leading the way in how other agencies, particularly in rural areas, may be able to function. And so I thank you very much. So we've got a question. James, how many resources have you implemented, or how many responses?
So we like I said, we run about 3,000 calls a year, and about 20% of those are behavioral health or substance use disorder crisis. And we always initially send, we may also send the ambulance, but we always initially send a community paramedic to those calls. And about a third of the time, they end up going to an alternative destination. About a third of the time, they stay at home. And the other third of the time, they end up having injuries or illness that needs to be evaluated in the hospital. Although our statistics this year are treating a little bit differently, because we've added telehealth, where we have the ED physicians, and we're seeing that only about 25% of those clients are actually going to the emergency room at the end of 2020 through October, November of 2020, and then into January of 2021.
It's remarkable.